Hello everyone and welcome to Module 13. This is our last week on proteins and we're going to discuss the role of proteins and their relationship with different kinds of health conditions. We'll have just one more lecture after this on the interrelationship of macronutrients in metabolism. Okay, so our learning objectives are to explain the role of proteins in different scientific fields, explain the role of proteins in allergies and bone health, and explain how diet can impact mood and depression. Okay, so first I want to talk about the role of proteins in different disciplines. And the reason that I want to do this is because our healthcare system is becoming increasingly interdisciplinary, which is a great thing for our clients because they can get different type of expertise about whatever condition they are seeking help about. So first I want to talk about proteins and sports physiology. So I had quite a few requests that we talk about protein supplementation, especially in athletes. So I do want to touch on that right now. So for untrained individuals, the research tells us that there is likely no impact of protein supplementation on lean muscle mass and muscle strength during training. However, as a person becomes more trained in their duration, frequency, and volume of training, then protein supplementation can have a beneficial effect in that it can promote muscle hypertrophy and enhance gains in muscle strength. And for those of you who are interested, there is an article citation right here. I might assign that this week. We'll see. Okay. We also know that protein supplementation may accelerate gains in both aerobic and aerobic power, and that the amino acid beta-alanine, as well as the nitrogen-containing chemical creatine, may suppress fatigue. So creatine is a nitrogen-containing chemical that's not really a protein per se, but it is nitrogen-containing, and it's part of the energy release system of muscles. And in the diet, we can find it in meat, which makes sense because we find it in our own muscles. And creatine helps to transport extra energy to muscle and allows muscle proteins to continue contracting. Phosphocreatine serves as a storage reservoir for regenerating ATP. Okay, next we have the role of proteins in virology and immunology. Now, as we know from our previous lecture, proteins are an important part of viruses, and they're also an important part of antibodies that help our immune system function. So this is a little bit of a review from last week, but we know that antibodies are synthesized in response to an antigen that our body sees. So our body sees the antigen, we create an antibody to fight it off, and then we keep that antibody in our body so that we're more easily able to fight off the antigen next time. Now, viruses at one time were just considered straight out negative, bad news wrapped in a protein. However, new information is coming out in which we are seeing that not all viruses have a negative impact on health, and some may actually have a symbiotic benefit to health. So again, if you'd like to look at that reference, it's on the bottom here. However, what we do know is that when we are deficient in protein, then it does decrease the ability of our immune system to function optimally. So in this way, we may interact with virologists and immunologists in the field when we're counseling clients on protein intake. The next field is microbiology, and where this stems from is the fact that our global population is growing at a rapid rate. And one of the biggest concerns is, of course, food supply, and specifically protein supply, because we know that we need to have a source of high quality protein for every person, ideally every day. That said, we have microbiologists that are seeking to increase the world's protein supply by growing protein in a different way. So some of the examples can be shown here. Um, so first we have yeast here, and yeast can be grown on molasses or even petroleum and has a very high concentration of protein. We also have algae um, that have an extremely high yield of protein per gram of algae. We have spirulina here, which can grow in salty lakes. So these are all really innovative solutions about how we can feed people protein in the most efficient way possible. Excuse me. However, if you look at some of these things, these are exactly the foods that we get blamed for as dietitians for asking people to eat because they're green and they don't have high acceptance in our culture. So um, time will tell if these foods become more accepted, but they certainly are a step in the right direction for the solution for this problem. And we also need to develop our technology in order to harvest these proteins in an efficient manner. Oh, and I should say that the algae up here does include seaweed. Okay, next we have proteins and allergies. So this kind of ties in to what we just talked about with the immune system. So we know that proteins are very relevant in the field of allergies. So allergic reactions can occur when intact proteins are absorbed from the GI tract. And this is especially relevant when we're talking about infants. So, this is one big reason why we don't want infants to consume solid foods before 4 to 6 months of age because they have this GI tract that is not completely closed. And it's meant to be like that, really. We want a baby's GI tract to be kind of open because we want them to absorb antibodies from mom's milk, ideally. However, if foods are introduced way too early, then they can absorb those intact proteins. The body sees them as foreign, and the individual can develop an allergy to these intact proteins. Okay, the next field is in osteoporosis and bone health. Um, so the relationship between protein intake and bone health is a bit controversial. There's been research on both sides that has said, okay, does it increase bone degradation? Does it increase bone synthesis? Is there no impact? So, the current evidence shows us um, is that there is a positive association between protein intake and bone health, and that protein intake actually improves bone density and reduces risk of fracture. And you can see again this reference down here, and I'll also assign an article on it this week. So past concern is that high protein diets have acidifying properties because, well, I'll say that in a second, have acidifying properties which have an adverse impact on bone due to increased urinary calcium excretion and bone loss. So the thought would be that proteins have, especially animal proteins, have high sulfur amino acid content, and that could increase bone resorption because it would cause a release in bicarbonate from the bone to neutralize the acid from the protein. So this was one concern. However, we see that in total, it doesn't really have an effect. And if it does have an effect, then the real concern is animal proteins and not really plant proteins. So, in the research, in the literature as a total, we see that there's really no support for a causal relationship with whole body calcium balance, bone resorption, and changes in bone density or fractures with total protein intake. We also know that protein intake can actually increase bone anabolism, which means it can actually help increase our bone density. So there may be mixed ideas on this. To summarize, however, we don't see a relationship with total protein and bone health, and if there is a concern, then it would probably primarily be with the animal proteins. Okay, now what about proteins and renal stones? Generally, we know that a combination of a low calcium diet and a high animal protein diet can have a negative calcium balance. And that means that calcium is going to be released in our bloodstream and potentially increase our risk of calcium stones. Um, and we know that indeed animal protein is a risk factor for calcium stones. So this kind of ties into what we just talked about with bone health. That's really animal protein that would be the primary concern. However, when we actually look at how animal protein in the diet impacts calcium stones, we see that there is variability according to sex and BMI. So, for instance, animal protein seems to be more highly associated with calcium stones in men than in women. However, though we see that a high protein diet does have this effect in certain groups, when we lower protein, we don't see a parallel decrease in the risk of kidney stones unless we also implement a high calcium, low sodium diet with the low protein diet. Okay, now let's talk about protein and stress related mood deterioration and depression. Now, plasma tryptophan, we know that tryptophan is an amino acid, is converted to serotonin. And we have a figure here. So, just through a few steps, we convert tryptophan to serotonin. We also know that amino acids tyrosine and phenylalanine are precursors for catecholamines dopamine, norepinephrine, and epinephrine. So it's easy to see why protein intake, and especially intake of these specific amino acids, could alter our mood or our risk of depression. Now, how would this really work? So we have large neutral amino acids, tryptophan, phenylalanine, tyrosine, leucine, and isoleucine, and valine. And all of these large neutral amino acids are competing for attachment on the same transport carrier located at the blood-brain barrier for uptake into the brain. So, just like our other conversations on competition, we know that when we increase the proportion of one of these amino acids, then it has a better chance of competing and being incorporated and taken through the blood brain barrier. However, if we just increase our total protein intake, it's not really going to have an effect because it's not going to alter the proportion of the large neutral amino acid that is taken up into the brain. So, the effect of manipulating one of these amino acids, for instance, plasma tryptophan, on brain biochemistry, is not going to depend on the tryptophan per se, but the ratio of plasma tryptophan to the other competing large neutral amino acids. Okay, so in this way, we can alter our food intake somewhat to impact the synthesis and function of different neurotransmitters in the brain by changing the concentration of the different large neutral amino acids that we take in. So let's think about protein foods. Okay, so protein foods have a relatively low concentration of tryptophan, but they have a lot of other large neutral amino acids. So there's lots of competition when we eat protein. And really, though we would think, hey, if I'm going to eat tryptophan and tryptophan is converted to serotonin, then it should increase my mood. Not so, because if we're taking in protein foods, we have a lot of competition with other large neutral amino acids. So it's going to actually decrease the tryptophan's ability to compete and be taken across the blood-brain barrier to be incorporated into the brain. However, carbohydrate-rich foods are found to increase the ratio of tryptophan to large neutral amino acids because they don't have a lot of large neutral amino acids. They aren't composed of a lot of these large neutral amino acids. So this gives tryptophan an advantage in the competition for access to the brain. And this increase in blood tryptophan is produced by the mechanism by which this happens is that when we eat carbohydrates, we have an elevation in our insulin. And with the exception of tryptophan, this insulin causes large and neutral amino acids to be taken up into the skeletal muscles for conversion to protein. So really we have two things going on here. When I'm eating carbs, number one, I am not providing the other large neutral amino acids to compete with the tryptophan for incorporation into the brain. That's one thing. But also the insulin from my carbohydrate intake is going to promote uptake of these other large neutral amino acids into my muscles, thereby also decreasing competition for the tryptophan to be to compete and go into the brain. Now, we see that when we do try to manipulate our diet in order to increase production of brain serotonin, we do have actually a modest effect in individuals who are very prone to depression or who are in very stressful conditions, but we don't have this negligible impact on healthy individuals. So let's look at this graphic here. So we talked about when we have protein intake, we have a lot of large neutral amino acids and just some plasma tryptophan, and therefore we have kind of a low ratio of tryptophan to large neutral amino acids, and therefore we will have less brain serotonin. However, when we eat carbohydrates, we have an insulin response. We don't have, this decreases the amount of large neutral amino acids in the blood because number one, we're just taking in less, and number two, the insulin is causing them to be taken up into the muscles. However, this allows us to, it doesn't cause the tryptophan to be taken up into the muscles. Therefore, we have a higher tryptophan to large neutral amino acid ratio and higher brain serotonin. And this really makes sense when we think about carbs being kind of our happy food because they create a larger increase in serotonin. Okay, so here are your practice questions for this first part of the lecture. And now I want to focus on proteins and metabolic disorders. Okay, so our learning objectives for this section are to list and discuss the metabolic disorders of proteins, including PKU, maple syrup urine disease, tyrosine, alkaptonuria, I always have a hard time saying that one, and homocystinemia. We're also going to discuss homocysteine and its relationship to heart disease and explain the differences in protein in different types of protein energy malnutrition, including marasmus and kwashiorkor. Okay, so first let's talk about alkaptonuria. So we're going to see in a lot of these metabolic disorders that we talk about the first time that they're all involved in this, in this first part, that they're all involved in the same pathway. So alkaptonuria is a disorder of phenylalanine and tyrosine metabolism. So let's find here. So alkaptonuria is here. So here we have phenylalanine and tyrosine from the diet, and normally they would go through this metabolic pathway to produce fumaric acid and acetoacetic acid. However, in alkaptonuria, the body is unable to utilize homogenostate an intermediate in this metabolism in the liver. Therefore, we have a deficiency in this homogentisic acid. Sometimes it's called dioxygenase, sometimes it's called oxidase. You can call it either. You might see it as either. So then, since we don't have this enzyme to break down this homogentisic acid, this begins to build up in our bloodstream. And its oxidation products accumulate in the body and are excreted in the urine. And so with this disorder, we see urine that is dark brown because of this homogentisic acid that is built up in our bloodstream. And it turns brown or black when it's exposed to the air because the homogenosate is being oxidated when it's exposed to the air. So diagnosis doesn't depend solely on this darkening of urine when it's exposed to the air, because we also see this darkened urine in other conditions as well. And it could also be myoglobin or hemoglobin or bile in the urine. So alkaptonuria is considered benign in childhood. However, later in life, we would see symptoms from this disorder, including ochronosis, which we would see develop in maybe about the fourth decade of life. And this is a result, it's the same exact reason why we see this discolored urine. It's the result of this homogeneous acid pigment accumulating in the blood and in the connective tissue and producing an abnormal pigment with a bluish hue. And we can see different examples of this on the face over in these pictures here. So it could be a bluish gray discoloration on the external ear, followed by the nasal cartilage and over the maxillae. We might see small joints that are discolored, especially over tendons. We could also see a brownish tan stain in the genital area and anywhere where perspiration occurs. And this ochronosis is, we also see an impact on the joints because the homogenosate is collecting in the joints. We have an impact of arthritis, and this arthritis is chronic and progressive, where the joints become gradually rigid and producing a stooping posture. And once this ochronosis is established, this coloring and this arthritis, there is no treatment for it that we can reverse it. In some individuals, this ochronosis isn't really pronounced, and therefore some people may have this condition and they don't even know about it. Okay, next let's move on to maple syrup urine disease, which I'm sure many of us have heard about. The formal name for this is called branch chain ketoacidemia, and it's caused by an enzymatic defect in the metabolism of our branch chain amino acids. And this disease, counter to the alkaptonuria, which we only see later in life, this disease we see present as early as the first week of life. And it's manifested by the accumulation of branch chain amino acids and their keto acids in the spinal fluid of plasma. And these concentrations can be 7 to 14 times higher than in normal individuals. So the presence of allo-isoleucine is diagnostic since it's not known in any other condition. So by noting this in the bloodstream, then we can say that this is definitively maple syrup urine disease. And in this disease, individuals do have a characteristic color and odor of their urine, skin, and perspiration. So it has a sweet caramel-like malty brownish smelling like maple syrup. And you can see in this picture here a container of normal urine in compared to urine from someone who has maple syrup urine disease. So it's pretty evident. Again, an individual would note this in the first days of life, and we may see it expressed as irritability, refusal to feed, poor weight gain, poor reflexes, etc. And these symptoms are progressive. So, infant could experience alternating periods of hyper or hypotonicity of their muscles, convulsions, seizures, and this could even progress to coma or respiratory disturbances that are fatal if this hasn't been treated. Uh, um, a rare infant could survive. A rare infant who wasn't treated could survive, but usually they have a condition of mental retardation, though we're not really sure of the etiology of the mental retardation in this disease. Um, Now, if we do treat these infants, they can survive, but then often they are susceptible to secondary infections such as pneumonia and ear infections, pharyngitis, etc. So for dietary management, it's just what we would think. We want these individuals can't break down branched chain amino acids, so we want them to have a branched chain amino acid free diet. So we would take away all of the branched chain amino acids from the diet and only provide enough to for the individual to function. So what's important is that when an individual has these branched chain amino acids built up in their system, and we try to return them to normal, isoleucine and valine will return to normal before leucine. And so we need to supplement with solutions of just those two amino acids to prevent a negative nitrogen balance of amino acid deficiency. Because when we have this amino acid deficiency, then our muscles are going to break down, and then the individual will have even higher branched chain amino acids in their system. Okay, the next condition we're going to examine is hereditary tyrosemia, and there's two types of this tyrosemia. So again, we're sticking with this same pathway, and in type 1 tyrosemia, it is impaired tyrosine metabolism. So again, the tyrosine or phenylalanine that we get from the diet is not going to be broken down to fumaric acid and acetic acid as it would in a normally functioning individual. Hold on one second. Okay, sorry about that. So in tyrosemia type 1, we have a deficiency of this enzyme here, this fumaryl acetate hydrolase enzyme, so that we can't break down tyrosine into its final products. And this results in the accumulation of this fumaryl acetine acetase and succinyl acetone, though the mechanism of this condition is complex. And again, this is an autosomal recessive condition, and it's most prevalent in the French population and in their descendants living in North America and in the Scandinavias. So in the early stages of type 1 HT, the individual would experience vomiting, diarrhea, failure to thrive, abdominal distension, and other complications are listed here below, so I'll let you read through that. Now, we do need to distinguish this type 1 HT from transit neonatal tyrosemia, and this TNT would be due to immaturity of the enzyme system rather than a deficiency in the enzyme system. So this could be common, this TNT could be common in premature infants, and in some infants fed a high protein diet with inadequate vitamin C. But the infant would respond easily to treatment in this TNT. However, if they don't respond to the treatment, then we can assume it's this HT type 1. Okay, we also have HT type 2, which is less frequent, and it's mainly distinguishable by these keratitic skin lesions. Um, on the hands especially, and also by mental retardation. And again, the etiology of this mental retardation is unknown. Tyrosine restricted diets do give dramatic relief to the skin lesions and to cerebral functions, but this dietary intervention is insufficient to restore a normal metabolic phenotype or to prevent deterioration of the liver that occurs with this type 2 HT. Um, One medical treatment would be a liver transplant. However, of course, would have to weigh the risks and benefits of a liver transplant in comparison to this type 2 HT. And prenatal diagnosis is available through the amniotic fluid, through testing the amniotic fluid, which again comes with its own risks. Okay, next is a condition that many of us are probably more familiar with, which is phenylketonuria, or PKU. This is a congenital impairment of phenylalanine metabolism, so we're still on the same pathway that we've been talking about. And it's a deficiency of the enzyme phenylalanine hydroxylase, which impairs the liver's ability to convert phenylalanine to tyrosine. Therefore, phenylalanine builds up in the liver. We also see high phenylalanine concentrations in the kidney, where phenylalanine is converted to phenylpyruvic acid, which is a ketone body. And this high concentration of this type of ketone body can cause brain damage. Now, newborn infants with PKU do appear to be clinically normal, which is why we do this skin prick test to test for this metabolic disorder so that we can address it before there are clinical symptoms. This is one of the most widely applied genetic tests for any infant that's in the hospital. They're typically tested for PKU unless the parents opt out of that testing. And the pathogenesis of the brain damage isn't fully understood. So again, we see that this cognitive disability that accompanies some of these metabolic disorders, we don't fully understand. Oh, I do want to say that this phenylpyruvic acid that we see accumulated in the kidneys, we can test that in the urine, but it may not be evident until a few days after birth when the negative consequences are already starting to build up for PKU, which is why we test the blood right away. So we need to know right away so that we can begin dietary management immediately. And management of the diet requires providing only enough phenylalanine necessary for growth, but not enough that it would need to be broken down, except the individual doesn't have the enzymes to break it down, so it would accumulate. So what we're trying to do is maintain phenylalanine levels within acceptable limits, and supply nutrient and energy in amounts to support growth and normal intellectual development. Now, this is tougher than it may seem because all naturally occurring food proteins do have phenylalanine. So this would require maybe a special type of formula or just an extremely restricted diet. And here's the pathway here where we have dietary protein and tissue protein being broken down to phenylalanine. However, it can't be converted to tyrosine because we don't have the phenylalanine hydroxylase. So instead, it's converted to these other metabolites that can build up and be harmful. So here's an overview of what we've just talked about in the pathway, in this same pathway. So here we have phenylalanine converted to tyrosine, and we know that in PKU, it's this it's a deficiency in this hydroxylase enzyme that's leading to buildup of phenylalanine. Here we have tyrosine transaminase, which is deficient in tyrosemia type 2. We didn't talk about tyrosemia type 3. We have this homogenostate oxidase that's deficient in L-captonuria, and we have this fumarate acetoacetate that is deficient in tyrosemia type 1. So we can see it's this one pathway that is associated with many metabolic disorders. Okay, now let's switch gears here and talk about homocysteinemia. So homocysteine is a sulfur-containing amino acid formed during methionine metabolism. And homocysteine is metabolized by one of two pathways, remethylation and transsulfuration. So I think you've seen this before, but I'm still going to go through it. So in the remethylation, so where is our homocysteine? Here's our homocysteine. So in the remethylation process cycle, homocysteine is salvaged by the acquisition of a methyl group from a reaction catalyzed by methionine synthase. So it's going to pick up a methyl group here with the help of methionine synthase enzyme, and it requires a B12 cofactor. Now, this 5-methyl THF is the methyl donor in this relationship, and the N5 and N10 MTHFR is reductase functions as a catalyst in this remethylation process. So here we have our catalyst in this remethylation process. We have our methyl donor is transferred onto this homocysteine, and then it's reconverted into methionine. And we'll talk about why this is important moving forward, but what we need to know right now is that homocysteine is associated with negative cardiovascular outcomes, so we want to decrease homocysteine levels. So one of the processes is this remethylation process. The other is this transsulfuration process. And in this transsulfuration process, the homocysteine condenses with serine to form cystathione in a reaction catalyzed by a B6-dependent cystathione beta synthase. Cystathione is subsequently hydrolyzed to form cysteine, and this in turn can be incorporated into glutathione or further metabolized to sulfate and excreted in the liver. So these are the two pathways by which homocysteine can be converted to less harmful molecules. So a deficiency in any of these vitamin cofactors can promote hyperhomocysteinemia because our enzymes don't have the cofactors that they need to function to convert this homocysteine into methionine or into cysteine. So diets that contain an abundant amount of methionine also require sufficient amounts of B6, B12, and folic acid to prevent the buildup of homocysteine in the blood. And here are the normal homocysteine range. So why do we care about homocysteine in the blood? Well, we know that vascular disease is directly correlated with homocysteine levels, even within normal range. And clinical symptoms of homocysteinemia include those of the nervous system, cardiovascular system, musculoskeletal, and hematopoietic systems. Homocysteinemia is also associated with mental retardation, although an individual can have homocysteinemia without mental retardation. And other causes of homocysteinemia, other than this deficiencies of these cofactors or high methionine diet, would be chronic renal failure, hypothyroidism, pernicious anemia, carcinoma, certain drugs, and smoking. Now, why we care about homocysteine is that it increases formation of oxycholesterols and other oxidized lipids and proteins during the modification of LDL in our blood vessels. And we know that this oxidation of LDL causes the buildup of these fatty plaques, which then leads to cardiovascular disease. Now, we don't quite understand the mechanism entirely, but there's a possible interaction between homocysteine, lipoproteins, and cholesterols that involves altered oxidative process with cells developing these atherosclerotic plaques. So we do have one form of homocysteine, the thiolactone form, that is highly reactive and causes elevation in triglycerides, LDL, and cholesterol. So here I'm just going to give you a little video on a reminder of the atherosclerotic pathology. Hopefully this one works. Oh no. Okay. Well, I will put the right link in there before I post it, and then you can watch it on your own. Okay, so thiolactone form of homocysteine reacts with LDL to produce an aggregated dense form of a lipoprotein that's taken up by macrophages to form foam cells. When the LDL contains homocysteine, the peptide bonds in the amino group of the apolipoprotein B, sorry, just a second. Oh, sorry. LDL contains homocysteine in the peptide bonds to the amino acid groups of the apolipoprotein B proteins in patients who have hypercholesterolemia. So this suggests that the LDL cholesterol aggregates to carry homocysteine in the bloodstream to foam cells of early plaque, where the amino acid modifies this oxidative and synthetic process of the artery walls, promoting atherosclerosis. Now, one cause of homocysteine could be dietary, genetic, toxic, or hormonal factors that will decrease these processes that will convert homocysteine, that is, the remethylation and transsulfuration processes. Now, we know that excess homocysteine in the form of thiolactone converts LDL to aggregates that are transported in the blood and taken up by the macrophages in the arterial intima. We also know that oxidative modification of LDL promotes the formation of foam cells, that is, releasing lipids and cholesterol into these fatty plaques in our arteries. Homocysteine also facilitates smooth muscle hyperplasia and fibrosis, thereby increasing blood pressure and decreasing the blood flow through our arteries and blood vessels. Now, overproduction of oxygen radicals, we know, causes damage to our blood vessels and oxidizes portions of our gags, activates elastase, incites thrombogenesis, and increases calcium deposition. And all of these actions lead to an increase in atherosclerotic plaques that are implicated in cardiovascular disease. Now, autooxidation of homocysteine specifically produces ROSs, specifically hydrogen peroxide, that are implicated in this vascular toxicity of hyperhomocysteinemia. So the fact that the LDL carries this homocysteine with it as it's being taken up by those macrophages, forming these foam cells, is going to cause increased reactive oxygen species production. And these ROSs are going to cause further damage to the endothelial lining. And as you'll see in the video when I load it onto the correct PowerPoint, and as you know from your past courses, it's these tears in the endothelial lining that are really the initiating factors for buildup of these fatty plaques. So this homocysteine really supports LDL oxidation and the formation of these fatty plaques. Now, whoops. Before I move on to protein energy malnutrition, I do just want to say that though we know that homocysteine is associated with vascular damage, and we know that people who have high homocysteine are at higher risk for cardiovascular disease, it seems that there is mixed research when it comes to interventions to lower homocysteine and their effect on ultimate cardiovascular disease. So, what I'm saying is, let me take the example of renal disease. So, we know that people who are on dialysis and who have renal disease have high homocysteine levels. So, there's been a lot of effort to supplement these individuals with folic acid and B6 and B12 in order to lower homocysteine levels. And we've seen that those interventions are successful. We are able to lower homocysteine levels. However, what we don't see is when we lower these homocysteine levels, that is associated with an ultimate decrease in cardiovascular disease. So this is one more example of how we may be able to alter biomarkers, but we don't know that ultimately has an impact on these hard outcomes that we're actually the most concerned about. So this is just kind of something to think about and to keep in mind as you're looking at the research moving forward and as you're counseling your patients. Okay, let's switch gears to protein energy malnutrition as another metabolic disorder of proteins. And as I'm sure we all know, we have two main forms of PEM: kwashiorkor, which is a diet with excessive non-protein calories from starch or sugar, but deficient in total protein and essential amino acids. So in kwashiorkor, the person may be getting enough calories, but they're not getting enough protein and especially essential amino acids. In contrast, we have marasmus, which is a general wasting disease, which is deprivation of energy and proteins. And so these are kind of two opposite ends of protein energy malnutrition, but there's a lot of intermediate forms in between these two forms. So kwashiorkor is less common, and it tends to be confined to parts of the world. That's a typo. That before I forget. Where staple and weaning foods such as yams and sweet potatoes and green bananas are very prevalent, but the individuals aren't consuming high protein sources um, with those starchy foods. So that could cause kwashiorkor, and especially in a growing child. Um, so again, kwashiorkor is less common, and usually we would see kind of an intermediate form of kwashiorkor and marasmus when we see these characteristics of kwashiorkor. And the pathogenesis of kwashiorkor is not fully accepted by experts in the field. Conversely, we have marasmus, which is the predominant form of protein energy malnutrition throughout most non-industrialized countries, and it is associated with early abandonment or failure to breastfeed or with watering down formula, and it's associated with impaired immune function and consequent infections, including especially gastroenteritis. Okay, so what's the pathophysiology of these forms of PEM? Well, in kwashiorkor, we have increased carb and decreased protein intake. This leads to decreased visceral protein synthesis, low albumin production, and consequent and dependent edema, um, and impaired lipoprotein synthesis in the liver. So the reason that we would have this edema is because of this decreased visceral protein synthesis. You'll remember back that one of the functions of protein is that this fluid balance. So if we don't have adequate protein, we don't have adequate fluid balance. And this can also happen when a hospitalized patient is fed glucose for many days without adequate protein. In marasmus, energy intake is insufficient to meet requirements, so the body draws from its own stores, and this can often occur from early weaning to bottled formula diluted because of poverty. Okay, now in both marasmus and kwashiorkor, children are likely to have diarrhea, infections, and multiple nutrient deficiencies because both of them have protein deficiency. However, we have a lot of differences between these conditions as well. Now, separating these two into two separate classifications really oversimplifies these conditions, but at their extremes, these two conditions do have marked differences. So, marasmus we usually see in younger children, whereas kwashiorkor we see in older infants. Um, Marasmus usually develops slowly and is chronic, whereas kwashiorkor is often acute. Marasmus, we have severe weight loss, whereas in kwashiorkor we might have some weight loss, but it's not as extreme because we still are getting some calories into the kiddo. In marasmus, we have severe wasting, whereas in kwashiorkor it's more moderate. The growth retardation is more severe in marasmus. We are more likely to see edema in kwashiorkor as compared to marasmus. In kwashiorkor, we're more likely to see fatty liver. Um, in marasmus, we're more likely to see anxiety or apathy, whereas in kwashiorkor, it's we also see apathy, but there's more irritability, sadness. In marasmus, the child would still have hunger, wherever it is in kwashiorkor, they would be more likely to have anorexia. We have different characteristics of hair between the two conditions and of a skin between the two conditions. Okay, so we can diagnose these two conditions based on those differences that I just talked about. But it also differential diagnosis includes secondary growth failure due to malabsorption, congenital defects, and deprivation. Now, we do see these skin changes in kwashiorkor, and it might get confused with the skin changes that we see in pellagra, but they are different in the way that they occur on parts of the body exposed to light are symmetrical. Okay, so how do we treat protein energy malnutrition? Well, it's essentially the same for these two conditions. So in the first stage, we're going to rehydrate um, rehydrate the child, and we're going to try to address deficiency of nutrients, low body temperature, and we're going to try to treat secondary infections. In the second phase, we're going to begin to introduce foods and begin slowly increasing calories and protein. At this stage, the appetite may be poor, especially in the kwashiorkor form, and sometimes the child will need assistance with feeding. And then in the third stage, after about 3 weeks, when the children's appetite has improved but is still underweight, we're going to begin increasing our food even more to support weight gain. So catch-up growth could take many weeks depending on how malnourished the child was. And I think it's always important to remember, especially when we're treating children, but really when we're treating anyone, of the support system that it's going to take to bring these individuals back into good health. So a mother may need support and advice in the home if the home setting is unfavorable, or if there's poverty, which may cause further malnutrition, or if there's social disorganization. So mortality for PEM is rather high. It's 15 to 40%. There could be death in the first days of refeeding due to electrolyte imbalance, infection, hypothermia, heart failure. So this is why we always have to be careful with our refeeding regime and take it very conservatively, even though we might want to be more aggressive with it. Um, in PEM, behavioral development could be markedly retarded in severely malnourished children, and the degree of this mental impairment is really related to the duration and severity of malnutrition as well as the age of onset. So, what stage of development was that child in when they experienced these deficiencies? And the key to recognizing mild and moderate PEM are widespread, inexpensive materials in maternal and child health clinics. So these are very simple preventative measures: a weighing machine, a growth chart, measuring mid arm, upper arm circumference. So really, the challenge is not that we need all this equipment and tools. It's just getting moms in there regularly, getting them in there early enough, and being having the um, necessary food available to help treat this malnutrition. And here are your practice questions too about metabolic disorders of proteins. And that is all that I have for you today. Have a good day, everyone.